Thank you, Vincenzo, for this final wrap-up of the society recommendation. We have 10 minutes left for the discussion. I haven't received any text from the audience, so I think that we could start interacting between speakers if you wish. I have a question that is borderline with the systemic therapy we have addressed here. And I would love to ask you, expert, what is your opinion about the extent of lymphadenectomy that has recently come to our attention with the paper by Mazzaferro? And I understand an argument because not everyone is convinced that by extending the lymphadenectomy that will result in an improved survival of the resected patients. Is there any one of you, Professor Valle or Alejandro, that could comment on this? I'm quite anxious to know your aspect, and then Vincenzo, of course. Anyone?
Yeah, so thank you, Massimo. So usually the patients, once they come to oncology, we kind of know the answer that, we know how many lymph nodes have been removed and how many are involved. I think the key message that I take from the lymph node involvement, I guess, which would then inform the practice on lymphadenectomy, is what this is telling you about the biology of the disease. And I think what we need to understand a little bit better going forward is whether there is a difference in the way these patients or these tumors behave biologically, and whether that should influence treatment, whether that extends to surgery or indeed adjuvant treatment, which may or may not also involve radiotherapy. But I'm probably not the best place to then comment about the appropriateness of lymphadenectomy itself.
Thank you.
I think Alejandro wants to say something. If I can say something, it is important to note, in my opinion, that even the histological characteristic of the cholangiocarcinoma tell us a little bit about the spreading. For example, perihilary is really a lymph node spreading tumor. So, for example, I think that this is particularly relevant for the perihilar, and particularly relevant even for the large bile duct cholangio, that is a periductal infiltrating and the lymph node trophism.
If I might add a comment, probably the paper by Mazzaferro in the Journal of Pathology, there is a lot of methodological biases, and probably I invite all the attendees to read the editorial that has written Bas, because he clearly exposed all the limitation of the retrospective studies. Basically, this is a problem of misclassification due to the retrospective design of the study. Insist, I invite the people to read the editorial.
Which I did. Alessandro, good point. The next question is the perfect way of staging cholangio. Again, as far as lymph node spread is concerned, wish to have the opinion of these big experts. So you are here, Alessandro, then Professor Valle and Vincenzo. Which one is the best way for staging?
So I think. So go ahead.
No, Juan, you first.
Yeah. So we tend to currently use, as you know, kind of cross-sectional imaging, CT, and or MR as appropriate. PET is not routinely used at the moment in staging, although we do know from the work that we published previously that although PET is not very good at identifying T stage, it is able to help identify lymph node metastases as well as distant metastases, and of course lymph node recurrence. So in selected patients, we do sometimes also consider doing a PET scan, although we don't do this routinely for all patients. I don't know about other practice.
No, I wanted to add that in the ILCA guidelines, one of the recommendations were that if those patients that are potentially resectable, to run a PET scan based in the La Marca study that has been commented by Juan. I am author and panelist of the guidelines. I'm not very comfortable with the recommendation. I mean, I agree with the recommendation. I disagree with the level of recommendation, because we put a strong recommendation level, and I completely disagree with this level of recommendation, because it was based just only in the single study by Ángela Marca. That again, if you have listened to Juan, that he was the senior author, that he has also concerns regarding the validity of the study. Probably, in my opinion, when we have patients that can be potentially resectable, and by the CT scan we have any doubt regarding the adenopathies, we run a PET scan in those selected cases, because if there is a potentially suspicious of lymph node involvement in the CT scan, probably in the PET scan we can increase the accuracy of the staging. But routinely, I think that we just only using CT scan, body CT scan is enough to do the correct staging of cholangiocarcinoma.
If I can add something.
Yes, Vincenzo.
Oh, thank you, Professor. No, indeed, Alejandro, I agree with you. For example, sometimes you have a reactive lymph node, for example, in PSC, for example, or in patients that have cholangitis, or even patients with have stents, biliary stents. So what do you do in this case? So if the CT scan is not show a clear lymph node metastasis, probably the PET scan in this specific case could bring also false positive result, in my opinion.
In fact, in our cases,
sure.
if we have doubts regarding the lymph node involvement, even in those cases that are potentially resectable, we prefer to run an endoscopist ultrasonography to evaluate in much more appropriate way the lymph node involvement, rather than using or trusting in the PET scan. And in our particular practice, in those cases, particularly in the periliar, that are difficult to distinguish between inflammatory reactive lymphadenopathies and metastatic lymphadenopathies, we go directly to the ultrasonography, to the endoscopic ultrasonography, to check the lymph node involvement in very selected cases.
So, Alejandro, do you, to some extent, endorse the findings by Mayo when they were suggesting using EUS to expand our ability to pick up involved lymph nodes in patients with CCA, although their paper had some, in my personal opinion at least, referral bias problems, because patients were not homogeneously treated with all imaging techniques that we usually run in this type of patient. So do you agree that the EUs might
completely agree with the first point, that I think that endoscopic ultrasonography may be helpful in distinguishing the lymph nodes malignancy versus inflammatory, and also agree with your second comments that all these retrospective studies with heterogeneous management of the patients, there is a obviously risk of misclassification bias, as has been pointed out by the editorial by us in the Mazzaferro paper in Journal Pathology. This is the problem of all retrospective studies. There is a high risk of selection bias, of misclassification bias.